Hi, Mike Gibson, Kausik here, and we're talking about non-LDL targets for prevention of atherosclerosis. We lived through a couple of great decades getting LDL down to hunter-gatherer levels, and we've kind of maxed out at this point. We've had an improvement in outcomes, but CAD remains the leading killer. We have disease states like Lp(a), where 20% of the population is walking around with a genetic mutation, not modified by LDL lowering, not modified by exercise and other preventive strategies. So we have a lot of other targets out there that are for the taking. So, gosh, quickly bring us up to speed. Where are we at? Where are the targets? How are things advancing? I was pretty excited to hear about some of the RNA approaches to Lp(a). So give us an overview.
Sure, thanks, Mike. So I think that we've grown up with LDL as our principal atherogenic target in a world where now obesity, diabetes are becoming increasingly prevalent. We know that there are other ApoB containing most of what is in blood is in atherogenic particles, and it's very easy to remember. B stands for bad, and ApoB containing lipoprotein is in the form of LDL particles. Now, if your triglycerides are high, because you've got diabetes, poorly controlled metabolic syndrome, obesity, for example, you tend to get this atherogenic dyslipidemia of a low HDL and a high triglyceride. And for the triglyceride side, because they're contained in ApoB containing lipoproteins, you probably should be looking at non-HDL or particle number, so total cholesterol cargo or the number of bad particles, very simply. And so there's been a suggestion that we should be, and they've been around for a long time. Your first target is LDL, but you should be looking at, in those people, non-HDL and ApoB. So if your LDL target is 70, your non-HDL target would be about 30% higher, so 100, and your ApoB should be about less than 80 milligrams per deciliter. So that's where we are. In Europe, actually, we're actually a little bit lower. So we went to 55 for LDL, and so the non-HDL became about 80, and it was about 65 for ApoB, and I think that we're very clear on what we should be trying to do. The worry that some people sometimes have, if you make the targets too aggressive, we can't possibly achieve those. There's no argument about what's right. How you get there might take 5 years, 10 years, but let's not have that debate about what we should be doing in a high-risk patient. That's the first thing I would say. The second thing is, as you've highlighted very nicely, lipoprotein(a). We never used to look for it. It was a research tool, but there's compelling evidence about causality. Now, there are RNA-based therapies, because we can't really alter it any other way, of trying to reduce this atherogenic and prothrombotic particle by 80–90%, either with monthly antisense injections or 6-monthly sRNA-based therapies. And although current approaches to treating a person with a high Lp(a) is to manage all conventional risk factors as aggressively as possible, here you can actually target the direct genetic cause and normalize this.
If it is causal, you got to go right at the target, right? I mean, otherwise you're just preventing the other things around it. You got to go right at Lp(a), which is so exciting.
And Michael, I don't know if you've thought about it in this way, but just think about it, that for LDL, by maths alone, if you had to get an 80 or 90% lowering of LDL, you are in the realms of combination. No single drug on this planet will get you to an 80% LDL lowering. So you've got to use 1, 2, or 3 drugs to get there. Imagine for Lp(a), which is entirely genetic, 1 treatment that you need.
Yeah.
And you don't need 2 drugs, you don't need 3 drugs. If it's safe, we've got to show, though, that Lp(a) lowering reduces outcomes. And that's why these treatments aren't available at the moment, because we haven't been able, to conclude those trials yet. But when they're done, if we can show there's a benefit, that's going to really change things.
Game changer. It's almost as though the cardiologist is becoming more like like an ID person giving vaccines, right? I mean, once every 6 months, once a year. Are there any risk, and I know the answer is no, but just to be very clear, are there any risk in terms of anti-drug antibodies. I mean, RNA is not going to develop antibodies, right?
No, we've got data now with the Orion program that we presented a couple of years ago, up to about 3 years. We've just completed 5 years of Orion 3, and that data will be available hopefully at the end of the year, early next year for public presentation. But the data safety monitoring committees have been monitoring all of these, and you've never seen any kind of public concern. So you can make of that what you will. But all of the published data that we've seen, we've never seen any issues with anti-drug antibodies. We've not seen any attenuation of effect. And the reasoning behind this, Mike, is that RNA-based therapies, because of the way they work, they're so small, they're freely filtered by the kidney. So pretty much most things are out. Within 4 hours, because of this GalNAc modification, they all get into the liver. So there's nothing in blood after about 4 hours or so from pharmacokinetics. So it's got to be hanging around for you to try and drive an immune response. We've measured inflammatory cytokines and C-reactive protein. It's flat. You know, you don't see change in neutrophils, lymphocytes, white cell count, or other parameters that we see.
Or liver signals.
Or liver abnormal. Yeah, you don't see anything. And you know, and people get transient bumps because you've had a couple of drinks, you've had a viral illness, go up, go down. But the drug's there in the background. If it was doing something bad, it would be going sky high, right? You just don't see it. So, and that's not just with one drug, that's with multiple different targets as well, which to me speaks to the platform as being a really good tool.